Here's a question for Dr. Trefzer. Obviously, you mentioned about going to your oncologist armed with the research about hypothermia, and were the links on your PowerPoint there to research? Is that the sort of papers that would be good to go with, or do you have any sort of pack that you'd recommend?
So there's never such a thing like a pack like that anyone releases that prepares you in the optimal way. I think you need to do as much your own research, then it's authentic. Then you know what you researched for, what your questions are. If I give you a pack, it may not really address your precise personal problems that you would like to bring to the oncologist's attention. But hypothermia is such a widely researched field. You find if you specify what particular type of question you want to address with the oncologist and match it with hypothermia, you find quite a few links there.
We're starting a protocol with hypothermia at the Oasis, and the amount of information, scientific information, is vast and complete. There's no interest from conventional oncologists to do this, but the scientific basis for it is extremely compelling, and it's out there. And there's a lot of very, very good publications that you can find about how it works, why it works, and especially on as an adjuvant to chemo and radiation, there's a lot of information published in very good or respected, let's say, medical journals.
Okay, thank you. Right.
I went to a conference about a year ago with a German doctor who has a clinic in Germany and does hypothermia, but he made it quite clear that hypothermia works brilliantly, but only for a short period, and then you have to come back and do it again, and do it again, and do it again. And I wondered if you had any comment on that.
Yeah, there's no such treatment like hypothermia burns away all the problems. It's an immune stimulation treatment, and immune stimulation means to support the immune system maybe over months, over years of fighting a disease. So it's often good to enhance other treatments with using hypothermia. It doesn't mean you have to go back to Germany to have hypothermia treatment. So you maybe find your own devices. A lot of good devices now for home use. It's not a full Monty of the kind of full body hypothermia, but you get a lot of heat effect already that you can use. You can use exercise. You can use mistletoe injections, which is a fantastic way of stimulating pyrogens in your body if you respond to it. So you don't have to travel long distances. It's kind of slowly getting available.
It's not the distance, it's the repetition that I'm concerned about. It doesn't actually cure you, you actually have to keep doing it.
No, sorry, this is the point. It doesn't cure you. No, it doesn't cure you. Not as a one-off.
But with chemotherapy, will that cure you?
I cannot generalize this. It's often we know that the first round chemo is very efficient because it's very immune suppressive and cytotoxic. So it works for a long time. And if that would be less cytotoxic and would be combined with hypothermia treatment, where you don't kill all your immune competent cells and your bone marrow and your the microflora of your intestine, etc., then you have much more of a long-term chance to make that a real benefit.
Okay, this lady here.
Simple dietary question.
Right.
I don't drink milk, but I have been told to make homemade yogurt.
Okay.
Where is the influence of the estrogen? Is it too strong, or should one be avoiding yogurt? Yes.
It really all depends on the source. If
Coming from cows
if the cow is in your backyard and you know for sure that they have not been injected, you know, you can actually be pretty sure. Otherwise, there's going to be estrogen.
Actually, this is a question for everyone, but I just wanted to ask, in terms of sugar, we all know that cancer loves sugar, but what are your views on the carbohydrates as opposed to refined sugars? I mean, it's a bit of a minefield. I've been through breast cancer, and I'm really trying to get my nutrition on the right track. But how do I, in terms of carbohydrates, I'm a bit confused about, say, eating rice, pasta, and then I'm finding I'm losing weight because I don't know what to eat. So, and if I'm feeding my cancer and if I'm not feeding my cancer, I don't know. What would...
It is very complicated.
It is.
Because it doesn't matter what the source of carbohydrates, your body will lastly convert it into sugar. There's no question that low glycemic index foods are going to be better for a cancer patient. And there's a lot of publications that have shown that cancer patients will fare much better with a quasi-vegan diet, low glycemic index, than other type of diets. Quasi-vegan.
Yeah, but
Quasi, almost no protein. Almost no animal protein.
so no animal, but protein
From vegetables, yes. That is the diet that has, you know, proven, and there's a number of published papers on it.
And in your experience in your center, is that the case also?
Yes,
It is.
definitely.
About fish.
So very low consumption of animal protein. Doesn't matter which one. Okay, obviously it is better. It's the same. It's animal protein. So we all want to find something, you know. So the better you stick to the diet, the better you're going to do. Now, I have patients where I told them this, and you know, if after 3 months of doing this, you'd rather die than continue with that diet, well, that's not the diet for you. So we are somewhat lenient in that because life is about enjoying it. There are some people that, you know, they think like Germans, black and white. And this is what I have to do, I do it, and they enjoy life, that's fine. Most of us are like, well, I need some fun in my life, and food is a big source of enjoyment, so it is not easy. But diet can be very, very powerful for long-term results.
Yeah, I mean, often patients bring the similar questions. You know, should one eat carrots, for example? Okay, it's relatively high in sugar, but it also has beta-carotenes. It has a lot of good things. So how do you strike the right balance? And I think you have to sort of like use your own judgment a bit. To cut out all the starches and then you cut out all the wonderful beetroot it backfires. And many patients are in this slightly cachectic state where they lose body weight. And if you remember that slide where I showed this kind of matrix, you need some body substance for further reserves. You need to know what good starches to put into your body. And there's also the glycans, and so there's a lot there. But just the complete sugar, the complete sugar and carbohydrate is kind of is a radical. It's a kind of not viable with life. Concept that is, you create other problems, I think.
I think there's too much fear out there. I really do. I mean, I became frightened of a banana. It's a banana! You know, the fig. Mind over matter. I think, you know, I could be drinking green juice every morning and maintain a deep resentment or a deep anger or a deep fear or a deep something about something. The green juice isn't really going to do much. For me, to be going around fearing all the time what I eat is not helpful. And I asked this question to Anita Morjani, who some of you may know, who wrote the book Dying to Be Me and went to the other side. And I said, Anita, I get so tired of going to see that person, you can eat that, go to see, no, you mustn't eat that. Oh, you must eat meat. No, you mustn't eat meat. It's the only time I ever lay on the floor and wailed, literally just wailed, because in one day I'd made 3 phone calls and been told 3 completely different things. And I was tired, and I didn't know, what about me? What do I feel? What feels right for me? And a lot of the time eating carrot cake didn't feel right for me. But occasionally it did.
I did a review very recently of about 23 or 24 clinical trials, and I looked at the common denominator of the long-term survivors, and it wasn't the protocol. The long-term survivors were all the ones that kept their diet. And our diet is very lenient. Okay? We allow them some protein, and it's a diet that most people could do for a lifetime. And the conclusion that I got is that, even though the diet is very good, and it's providing the elements and it's avoiding some of the toxins, to me it was not sufficient to keep some sarcomas away. It's not sufficient. To me, the most important part about the diet is the messaging. What am I talking about? Messaging is so important in life, right? I mean, if anybody married here, mixed messages are bad. Well, mixed messages to you are bad. So let's say, well, I'm taking this treatment, I'm doing this, and I'm smoking. And so your body's going to go, well, what is it? Do you want to kill me, or do you want to heal me? And so I strongly believe that mind connection is so powerful that what is keeping a lot of patients alive is 3 times a day at least, you're telling your body, I'm making certain sacrifices because I want you to survive. And so that mental aspect, because, it's not just based on fear, it's also based on information. And as I mentioned at the beginning of my chat, I want to provide you information that will inspire you to make some changes, because there has to be some sacrifices. There's no question about it. If you don't make the sacrifices, well, you just want to go home sooner. But if you're negotiating for life, there's going to have to be some sacrifices. But if those sacrifices are made in such a way that the messaging is positive, you will then be able to make those necessary changes. Because yes, I'm very sad that I can't eat chocolate cake anymore, so I'm just going to eat chocolate cake. Well, your tumor is going to appreciate it. Yeah. There's no question about that. It doesn't matter how powerful your mind is. There are certain physical aspects that are going to determine whether you survive or not. How happy you're going to survive or not is a different thing. So again, if you want to die sooner, there's some things that you can do. And if you want to die later, there's some things that you can do. But as I tell you, that mental aspect, she's absolutely right. It's a lot more powerful than the physical entity of the sacrifice.
Hello, this is a question directed to both doctors. One area that we've not really touched on so far is the whole issue of post-treatment and monitoring. And just really, I'd like to understand more about the best approach to take. I know there has been mention of thermography and tumour markers and that sort of thing, which are obviously safe. But I'd like to understand more about how effective those modes of actually checking and monitoring are as compared to mammography and all the rest of it, which obviously carry their own risks.
In my experience, the reason why I don't recommend mammography is because the interpretation, as I've found now from several people that do it, is still very subjective. Sonography is a lot more subjective. That is, it's more standardized. Most people are going to interpret it similarly. And it's non-invasive, it has no radiation. MRI is probably the best, it's just too expensive. And then I only recommend mammography when there is actually something that I'm looking for. I do not recommend screening mammography. And again, with thermography, my experience with it, at least, with several people that do it, the interpretation is just too subjective.
Yeah, can I perhaps add? I think your question was also about tumor markers and what happens after you had several interventions. So you want to make sure you're kind of in a safe phase or space, and that's often a tricky area. That space easily fills up with anxiety, with more hype. You should have another, mammogram, for example, or checkup. And just in case there are a few tumor cells that have escaped, so you should maybe mop them up with another round of another treatment. So, and should you give in to that or not is often the dilemma you have to face. And is there anything you can do, sort of like it's called risk stratification. So what can you do to kind of to gauge where you are, where your immune system is, and how you feel is not always exactly what the immune system does, sort of quietly. So tumor markers is one such way of monitoring. However, one has to say that hospitals are often reluctant to just use them because it creates conflict. So by the definition of tumors and cancers, it's the visibility of them, what you see on a screen, on an ultrasound, on an MRI scan, etc., on X-ray. And if it creates conflict with what your tumor marker says, which is the biochemical aspect of it, which might be much more sensitive, then it creates conflict and no one wants debate. But it's good to bring debate into the discussion if you see an oncologist. So ask them to do, for example, in breast cancer, ask them to do CEA and CA153 and CA125 as a regular spectrum of markers. And then you might find one marker that is reactive to what's going on in your body. Use that as a tracer marker. And then you monitor. If that suddenly goes sky high, then it's most likely something has happened that more treatment intervention is required. If it stays stagnant and it was reactive before, then you can say, I think I'm doing well, whatever I'm doing, you're doing well. Of course, there are other markers, more sophisticated markers, more in the sort of like outside National Health Service range and also outside most people's financial range. You may have heard of nagalase and transcatolase and LDH and P53 expression, P53 and mutated P53, BCL2, so the range is endless. You need sort of like a clinic or a practitioner who helps you making selections, meaningful selections. But it's always worth looking and discussing that with other patients, discussing it with practitioners to kind of become a bit expert in your own field to know what's going on.
I'd like to ask if it's not metastatic breast cancer, what's the thoughts on surgery?
Very important. In early stage cancers, that's why we're always seeking to find the early stage. And early stage will be between 1 and 3, because it means that the cancer is regionalized to the breast and maybe the lymph nodes in the area. A stage 1, it's about 85% cure rate with a lumpectomy. That's how important it is. So what we're now doing is, when we find a patient in stage 3, for instance, is we want to bring that patient to a stage 1 in order to offer that kind of cure. And that's what we call neoadjuvant therapy, to reduce the tumor mass to the point that patient becomes stage 1. Still, the cure rate in stage 2 is about 60%. So it's very high. So with surgery. So the role that surgery plays in early stage cancers is still very high. If you don't want to do surgery, the cure rate drops by about 50%. It's very significant. So stating now that because alternative therapies can be very effective, will they be as effective as an 85% cure rate? No. So it still plays a major role.
Could you explain to me what dormancy of cells means?
We usually refer to a dormant tumor, a tumor that is stable.
Yeah.
Tumor that's not growing. And when a tumor is not growing, depending on the location, usually it's not a threat to you anymore.
If it's said that there are lesions in bone,
Well, that would mean that the tumor is stable, is not growing. It's not necessarily dead. It's alive, but it came to a point where it feels comfortable in that size without threatening your life anymore. If that protocol is maintaining stability, you will continue to do well. So there's two things in response that are very important to you. We have been sold on the cure, which is good, you know, but it just depends on what price you have to pay for the cure. But the second good result would be stabilization, where a tumor is not a threat to you anymore.
Okay, but it can start up at some
Anytime. In fact, tumors can go away completely, and the biggest problem is recurrence. So the fact that the tumors go away is no assurance that they will not come back.
Oh, okay, so it can disappear completely.
Yes, and still come back. Well, that's the problem with most cancers. You can get rid of them with the first line of chemo. You wiped out the immune system so badly that the tumors come back, and then those tumors are much more difficult to treat.
Can I perhaps help to clarify? The skeletal deposits is X-ray interpretation, and that often shows translucent areas in the skeleton. It's normally the flat bones of your skeleton. It's either the vertebrae or the ribs. So it's not weight-bearing bones. It's actually an area where nature can afford taking calcium and calcium phosphate out of the skeletal structure in order often to buffer metabolic acidosis. So it uses alkaline material to do some sort of intelligent reaction, but what happens then, you have pockets of osteoporosis in your spine or in any sort of flat bones where nature can afford it, and then the calcitonin or other hormones kick in, protective hormones, to redeposit calcium back again into these areas. And then you get this kind of on the X-ray appearance somehow, some slightly sort of moth-eaten sort of like signaling. And if someone looks at that at the wrong time, then you can jump to the conclusion that, hey, cancer has come back, let's use intensive radiotherapy, even if there's no back pain involved. I often see this. And I advise my patients not to panic in these situations, to try to explain to them what actually happens, and to use anything that alleviates the muscle spasm in that part of the spine. Use lymphatic drainage, osteopathy, aromatherapy, fascial release work, and touch wood, often that solves the problem. And they can 2 years later, it's a bit more calcium has been deposited into that area, so the spine is not suddenly going to break, or there's no cauliflower type structures growing out of that part of your spine. But yeah, you have to watch that field that's often created with these X-rays. And you can monitor also by measuring alkaline phosphatase, which is a GP can do that test. If it suddenly climbs up and goes very high, then you know it's there's a bit of a risk. But if that stays steady and there's no back pain or no joint pains, and you have a good diet and take all that vitamin D3 and have an alkaline diet and high minerals in your diet, then I think you might be safe.
I had breast cancer 5 years ago, and I was told it's very estrogen positive. And I started coming on some of these sort of seminars and reading, and I was told that body fat produces estrogen, so it'd be best to get my body fat down. I was told there was a correlation between VO2 max, or aerobic fitness, isn't it, and recurrence. So I went to a personal trainer, and now it's the best thing I've done actually since, for me, mentally as well as anything, since being diagnosed. And I do 2 sessions with him a week and 1 intensive class a week. I've got my body fat down from 27% to 20% so far. He wants to get it down to 16%. And I just wanted your views, really, because I do very intense exercise with him, and I've never felt as good. I feel fantastic. I'm doing races where I'm described as a county-level runner now. So I'm just so excited by it, you can tell. But I just wanted to hear your views on exercise. And
There's many publications on the preventive side, but there's also many publications on the adjuvant side of chemotherapy in cancer patients across the board, but especially in women. Because yes, estrogen is produced by our body fat, and also estrogen is a fat. So the more exercise you do, you will consume it. That's why high level women athletes will stop menstruating, because they go overboard in the consumption of estrogen. So for estrogen, even for non-estrogen dependent tumors, there are benefits, but especially for estrogen dependent tumors, exercise will prolong the life of a cancer patient, will respond better to chemotherapy, will respond better to radiation therapy. So there's many benefits. Not only that you enjoy your life more, because it gives you a lot more energy, there's also a lot of benefits hormonally on the side of hormones that make you feel better, give you a high. That's why runners are usually hooked to running, and if you don't have that, you miss it. So I would encourage everybody here. You don't have to be a long distance runner, but again, a half an hour of brisk walking a day, not window shopping, actually really walking, would be very good for all of us.
You said MRI. MRI can show whether a tumor is active or not. Is that correct?
Well, MRIs can actually determine whether it's malignant or not in some cases, but not active or not. Whether the tumor is there or not, yes. And it actually can point to malignancy or not. The only one that can tell you whether it's malignant or not is a biopsy. But there's other reasons why there could be a higher uptake of a tissue. So right now, even from the legal point of view, the only test to determine malignancy is a biopsy. But yes, the MRI and the PET scan can with a certain degree of certainty, say this could be malignant or not, depending on the uptake of the PET scan and depending on the image of the MRI.
Because as I understand it, there is a dye that is used in the MRI, and that shows whether it is active or not, actually.
Again, there are several scans that are physiological, okay, and other ones are just the image. The uptake of certain materials is to view the lesion better, not necessarily active or not. So they're two different things.
About hyperthermia, is laser a kind of hyperthermia? And what about sometimes now we hear that it's possible to have like high frequency radio ablation where you send heat directly in the tumor? And the second question about Dr. Francisco, for cases with metastatic breast cancer, I mean, you mentioned diet. With your experience, what are, let's say, the most successful to others complementary treatments between the list that we have, vitamin C, mesothelioma, hyperthermia, etc.? What is the best results that you are really getting in your clinic with those treatments? And for Sue, the fantastic Sue, at what period, when you have your cancer, is it in the beginning that you were able really to understand the connection between cancer and that you need to go through all your emotional journey? Or it took you really long time to discover this? And would you then recommend a psychotherapy for every patient with cancer?
And so the first question, laser is a cold light. Well, it can be also warming, but it's a coherent wavelength. It's quite different from infrared, completely different. So it's there to provide selective destruction of a solitary mass, for example, whether that's scar tissue or whether that's a tumor that is indiscriminate. Although certain wavelengths can be adjusted to what tissue type it is, there are studies that try to optimize that. But it doesn't have a scattering effect like, for example, infrared or or radiation treatment has a scatter effect. So it wants to reach the whole region. It wants to reach all the microfilaments and the lymphatic channels surrounding a tumor. And then the question is, we often get asked this question, should I use a laser to burn away my tumor? But what happens afterwards? You have a tissue mass that is not, it just doesn't evaporate. It's in your tissues. It creates an immune reaction, often a kind of inflammatory reaction, and it may even stimulate stem cells, which are not necessarily positive for to keep you in the safe space afterwards. So CyberKnife and other these modern techniques are from warfare technology. They're aiming in the same direction, but it cannot be in the long term successful unless it includes other aspects of harmonizing the terrain, the environment, and to also to monitor the response afterwards.
RFA, radiofrequency ablation, it's hyperthermia at the highest level, but it's very concentrated. For instance, you can put a needle in, and if the needle is for 4 centimeters circumference, 4 centimeters and 1/10 of a centimeter, the temperature is normal. It's amazing how controlled that burn can be. So we actually cook the tumor with radiofrequency ablation, and it can be quite effective in some tumors. Our metabolic therapy for breast cancer usually includes vitamin C, amygdalin or B17, the diet, a number of nutraceuticals for signaling transduction to target certain proteins, and a very important aspect would be the spiritual and emotional support that we give to our patients. Basically, we give them resources to reframe their way of looking at the threat of cancer, and trying to resolve a number of issues in their lives, especially resentment and anger. Those would be the most immune depressing emotions that you can have. And so the results that I showed are basically with that protocol.
So I knew immediately that this was my opportunity to make the transformations in my life. I'd been on a spiritual path for a long time and had been working emotionally with what had happened to me as a child for a long time. So I wasn't scared of cancer at all. When I was told I had cancer, I just wasn't scared of it. I was scared of chemotherapy. That's what I didn't want. And I've had chemotherapy, and it's fine. And actually, I resisted it so much. And interestingly enough, all the emotional things, or a lot of the emotional things I needed to learn, came during that period of having chemotherapy. I had to learn how to ask. I had to learn how to receive. I had to learn how to just be and not be distracted. I learned an awful lot during that period of chemotherapy. I got the support from my friends and family that I always desperately wanted. I got the love that I was always desperately yearning for. So actually, the thing I resisted most was where most of my lessons, deep, deep lessons came. And I think in terms of, most people know prior to cancer, getting a diagnosis, whether there's been stress in their life, whether something's gone on prior to that, whether there's been a particular incident or just an ongoing things aren't quite right. And if that is the case, which it was for me, then yeah, that's for me really important. And I think really important to stop it reoccurring, because I think cells are constantly renewing themselves. I mean, I got over chemotherapy so quickly. It was spring, and I was on the cleavers and the nettles, and it was like, wow, I'm back. Hair curly and looking good, and I was feeling great. For me now, I was told the cancer will come back because, you know, you've only done the chemo, and you haven't had your breast removed, and you haven't done the tamoxifen, you haven't done that. So, but for me, it's about staying happy, staying balanced within myself, And that's all I can do, continue to focus on my health rather than the fear of it coming back.
Dr. Contreras, it's a real privilege to be in the room and hear you speak. Thank you for coming to us today. I think it's amazing. I'd just like to challenge one of the points you made about the subjectivity of diagnosis from various diagnostic procedures. As a radiographer in my earlier career, I worked with a number of leading radiologists at a hospital not far from Harley Street. And I saw people who were spending some of their day doing general casualty radiology diagnostics, and then they'd do a bit of mammography and a bit of colonoscopy, barium enema. They were very much generalists, and yet they were making life and death decisions about the prognosis from X-ray images based on really very general exposure. They weren't specialising like many other practitioners such as yourself. And I just wanted to ask you to revisit the point you made that with thermography, how subjective that is, because surely someone who is doing it all the time is going to be able to operate at a much higher level of expertise than someone who's dipping in and out amongst a whole range of other specialties. Thank you.
You're absolutely right. The incidence or the rate of mistakes in interpreting radiology is very, very high. So instead of calling it imagery, we call it imaginology. So a lot of times, you imagine things that are there and you don't see the real things that are there. So the possibility of errors is very high. And that's why it's so important to trust the people that are doing this. And at least in our environment in Mexico, I have not found anybody to interpret thermography, especially breast thermography, that will give me a level of confidence to make a life and death decision. Hopefully it will come. It sounds compelling to me. I've read quite a bit about it. But again, when the interpretation comes is, well, what is it? Is there a mass or not? Is it infection? Is it a tumor? Is it and yet, at least in our environment, the technicians and doctors that are doing it, the interpretation that comes to me doesn't make me comfortable. And so I hope for the sake of women, especially for breast cancer, that it becomes more and more reliable.
Okay, a huge thank you to our panel. I think they've all been absolutely incredible.